This 37-year-old female patient was referred to us by her dentist. She had cracked her tooth and had gone to her dentist, and her dentist had recommended a root canal treatment. Her dentist had proceeded to do the root canal therapy, but according to the patient, no matter how many injections the dentist gave her, multiple injections, she could still feel everything. And at this point, she had become so anxious, nervous, stressed that her dentist had to stop and refer her to us so we can sedate her and proceed with the root canal therapy of this tooth. Again, she had cracked the tooth. You can see the dentist had put some temporary filling in there. Anyway, so when we saw her for consultation regarding this tooth number 18, we found the tooth to be part of the distal lingual part of the tooth was missing. Again, tooth was cracked. She had cracked it while eating, and there was a temporary filling there that her dentist had placed. Percussion very tender, palpation within normal limits, probings 2 to 3 millimeters all around. And patient had all the signs and symptoms of irreversible pulpitis with acute apical periodontitis. This was a hot tooth, basically. So we discussed options with the patient, and patient, as I said, she's 37 years old. She wanted to try to save the tooth. So that's what we did. We scheduled her. She came back. We sedated her and did the root canal for her. So take a look. Let's look at the point of view, clinical video of this tooth, root canal therapy of this tooth from A to Z. I'm using the Zoomax microscope here with the integrated 4K camera. So let's go ahead and take advantage of this microscope while I still have it, and I will teach you, I will show you how I did this root canal from A to Z. All right, so local anesthetic was given. I gave one Lido IA and one Marcaine IA. Rubber dam is placed. No rubber dam, no root canal. There's no arguing against the use of a rubber dam. I've noticed some of you guys argue. You say, oh, the rubber dam's not necessary. What are you talking about? When you say something like that, you sound so uneducated. It's like you never went to dental school, or the dental school that you went to. I'm kind of surprised that they didn't teach you the basic of infection control, the basic of fundamentals of endodontics. I mean, there are multiple studies that show the success rate of a root canal with and without a rubber dam. Without a rubber dam, the success rate is significantly lower. So there's no arguing. And of course, the chance of aspirating a file if you don't use a rubber dam. I posted a video recently. A number 10 stainless steel K file was aspirated by the patient, and it was being removed. The video I posted was removed from the patient's lung, and I posted a video on the removal, the process of the removal of this aspirated file that was in the patient's lung, dislodged in the patient's lung. And some of you still argue. You don't use a rubber dam, you introduce saliva and bacteria, of course, into the tooth, create contamination, future endodontic failure. You don't use hypo when you're not using rubber dam, because chances are that you use hypo, it's going to go down patient's throat. So I mean, there's so many positive. You keep the tongue and everything else away. So take a look. Anyways, I covered this topic, the rubber dam. a million times. All right, so you saw the temporary filling that the dentist had put in. Rubber dam was placed, as you can see. So let's go ahead and get started. Let's go ahead and remove the temporary filling that the dentist had put in. So it just came out, as you can see. This is the condition of the tooth. All right, this is a diamond burr. Let's go ahead and clean everything up. Any sharp edges or what have you, any unsupported denting needs to be removed, and that's what we're doing here. There's no rush in endodontics, so you take your time. Some of you ask me, how long did this take you? As long as it was necessary. So don't compare yourself to me. If it takes you 2 visits, then so be it. Take your time, do it properly. If it takes you 3 visits, so be it. Do it properly. Just because I can do it in less than an hour doesn't mean that now you have to push yourself and cut corners and do a lousy job because you want to keep up with me. Do it at your own pace. Take your time, do it properly, or don't do it at all. All right, everything is cleaned up, and take a look. That's what we have. That's what we have. That's what we're left with. All right, guess what I'm gonna do next? Just guess. Take a wild guess. What am I gonna do next? This is just extra temporary filling stuck there. I want to just clean everything up. Yes, I'm gonna rebuild the missing walls. I'm gonna rebuild the missing walls. This is a posterior composite that I'm gonna be using. Again, what I'm doing is not permanent. So I just do it. I just rebuild the missing walls so I can proceed with the root canal. And then I temporize the tooth and refer the patient back to their dentist, and then the dentist can make everything look nice and permanent and, you know, all that stuff that restorative dentists do. I'm not a restorative dentist. So I just do it so I can have 4 intact pulp chamber walls to keep everything within the pulp chamber and the canals, and make sure the pulp chamber is sealed with 4 intact walls. All right, that's one of the most important things. That's actually a fundamental of endo. One of the fundamentals of endodontics. All right. Let's cure it, light cure it. You see, I haven't even started the root canal. And take a look. Within a few minutes, a couple of minutes, now take a look. Look at the difference. Now I have 4 intact pulp chamber walls, sealed. All right, let's go ahead and make our endo axis now. All right, finally I'm entering to the pulp chamber. So you saw the preparation, you saw what it took before I start my endo. All right, so this is what we have so far. All right, so I've already made my endo access into the mesial. You can see the mesial canals right there, and I'm gonna break into the pulp chamber. I'm gonna unroof the pulp chamber using my ultrasonics, and this ultrasonics is the Ultraman Pro by 8 Teeth. I love it. You can use it wet, you can use it dry. I'm using it dry right now. And let's unroof this pulp chamber. You can see how easily I'm unroofing the pulp chamber with this ultrasonic device. Again, Ultra Mint Pro by 8 Teeth. My assistant is suctioning. My other assistant to my right is blowing air on my mirror. All right, unroofed. Very nice. I'm making sure that I have nice direct access into each canal. Direct access into each canal. Let's trough while we're at it for the middle mesial, just in case, if it's there. All right. Now I'm using my spoon to remove the bulk of the pulp tissue. Take a look here. You can see the bleeding, the amount of bleeding. That shows that this pulp was extremely inflamed. And that explains the fact that this was a hot tooth, and the dentist, no matter how many injections he administered to this patient, could not get this patient numb. Take a look here. Look at the amount of bleeding. All right. Excellent. Very good. Four intact, solid, and sealed walls. All right, let's go ahead and use our number 20 flare file. This is a flare file, so it's a stainless steel K file. The only difference is that it's got a 5% taper, and it's attached to my M4 reciprocating handpiece. All right, I need to make a little curve so I can get it into each canal. This was tooth number 18, and so lower left second molar, and her opening was minimal, so I had to bend my files to get them into the canals. All right. The M4 reciprocating handpiece runs at 1000 RPM, torque off. All right, so 08 C file now, and you see I'm not even using any hypo, and I'm not using RC prep or anything like that. As I always say, I'm using the juices of the pulp tissue, of the pulp, the juices of the pulp for lubrication in the beginning. All right, that's how I do it. All right, so whichever way you're comfortable with, you do it your way. Just because I'm doing it this way, if this doesn't work for you, you don't have to do it. I'm just giving you some ideas. Watch my videos and take what you want from them, and the parts that you perhaps maybe you disagree with or you want to do differently, or whichever part that you think you can modify and make better, do it. Make it your own. My goal here is to just show you how I do it, so you can get some ideas, the basic ideas, the fundamentals, and then you can modify it and make it your own. Again, I had to curve my OHC file. All right, so I'm in the mesiolingual canal right now. I did the mesiobuccal already, Again, I'm using the juices of the pulp. The reciprocating handpiece is running at 1000 RPM, maximum torque or torque off, basically. There's no torque. If the torque is on, it won't work. It's a reciprocating handpiece. All right, now that I've instrumented, I've tapered the canals with my number 20 flare file and used the 08C file to estimated working length. Now I'm using 6% hypo. So this is 6% hypo. And again, as you can see, my assistant is making sure that nothing gets out of the pulp chamber, of the tooth. All right. Now I'm using my 10C file. I'm in the mesio-buccal canal here to estimated working length. And you look how I'm using this reciprocating handpiece that I'm running at 1000 RPM. Remember, when I run it at 1000 RPM, I'm showing the canal curvature of the canal that the number 10C file took. When I run this reciprocating handpiece at 1000 RPM with hypo, filling the pulp chamber and canals, it not only instruments for me, it also activates sonically the 6% hypo. All right. You can't see here, but when you can't see, that means that I'm in the distal canal, because I had to angle the handpiece going from the mesial to distal, so it you can't see it. All right, so again, my assistant is making sure no hypo gets outside of the tooth. Again, 6% hypo after each instrument, after each file that we use, 6% hypo irrigation. All right, number 15C file now. Oh, I'm sorry, this is still number 10. All right, I wasn't satisfied. So take a look how I'm using my C file. I'm using it in an up and down motion and also in a brushing motion. I'm brushing with it, brushing the canal walls with it, and of course, brushing away from the danger zones, which means basically defurcation. So you brush away from the defurcation and towards the corresponding line angles. All right, again, 6% hypo. We use 6% hypo frequently and copiously after each file. And I'm going into the distal canal. That's why you can't see. I'm basically right now scouting the canals, getting a feel for their curvatures, and also creating a glide path for the night high files. That's what I'm doing right now. And of course, sonically activating the hypo to our estimated working length. Brushing, up and down, brushing motion as the reciprocating handpiece is running at 1000 RPM. Sonically activating the hypo at the same time as I'm instrumenting. You see my hand movements. All right, very good. Again, now I switch to the from the blue to the yellow. The yellow is thinner, irrigation needle is thinner, so I can go deeper into the canals. Just pay attention to how I'm using it, up and down, up and down. I would not allow the irrigation needle to bind to canal walls. And take a look. This is what we have so far. Look how nice and clean everything looks already. That's the wall, missing walls that I rebuilt using composite. All right, let's use our apex locator and get our working lengths. I'm using the Find Apex locator by 8 Teeth. It's a great apex locator, very accurate. Let's get our working lengths. You saw the pulp chamber was void of hypo. If your pulp chamber has hypo, is filled with hypo, then the apex locator will short because the current will jump from one canal to another. So you don't want hypo in the pulp chamber. You want hypo in the canals, a little bit of hypo in the canals, but the pulp chamber needs to be nice and dry. So take a look, 2 mesial canals, and as you can see, 1 distal canal. And again, I'm just trying to look to see if there is a middle mesial canal here or not. I got a little catch there, but as you can see, everything looks great. All right, so I got a little catch, right? I'm bending my 10C file, and I want to see if I can capture it. Is there anything? Is there a middle mesial there? So I put the C file where I thought perhaps maybe another canal was, and I didn't use hypo then because I wanted to see where I wanted to be able to see. And then when I put the C file in that the position where I thought that perhaps maybe there was another canal, then I asked my assistant to fill the pulp chamber with 6% hypo. All right. So yeah, there was nothing there. But I did explore it. So I didn't just dismiss what I was seeing. And again, you can only if your eyes need to be trained, because if your eyes aren't trained, you don't even know what you're looking at. So you don't even know what to look for. So the most important thing is to train your eyes and then accumulate knowledge and experience so you can actually see. Because you can look at a tooth like this and a middle mesial could stare you right in the eyes, but you can't see it because you can't recognize it. You can't recognize the anatomy. You cannot read the anatomy. So that's why it's so important to practice on extracted teeth, so you can train your eyes to be able to see. This is a number 12 C file. So I usually use a number 12 because jumping from a number 10 to number 15, that's a 50% increase in diameter. So number 12 is a good file to use in between number 10 and number 15 before using number 15. So the jump from number 10 to number 15, as I said, is pretty substantial. So number 10 is a good intermediary file to be used. All right. So now I can go to my number 15 C file to our working length. And again, pay attention to how I'm using this number 15. Up and down, brushing motion. I'm not only instrumenting with it, I'm also sonically activating the 6% hypo. I'm in the mesiobuccal canal right now, going to my working length. Mesiolingual now. Again, going to my working length and brushing away from the furcation towards the mesiolingual line angle. Up and down, instrumenting, and also activating the 6% hypo. And again, I got a little catch, and I caught it. Looks like there is a little fin off of alongside the mesiolingual canal. See, I'm in it right now. With just the fin, it was like a undeveloped middle mesial canal. Wanted to become a middle mesial canal, but didn't develop into a middle mesial canal. So it was just a fin alongside the mesiolingual canal, doing the same thing in the distal canal, up and down, brushing motion away from the furcation, and 6% hypo. Copious amounts of 6% hypo after each file. All right, so take a look. So I have a glide path basically to a number 15C file, but remember I brush with my files. So my taper is not 2% because I brush with it. So anyways, this is a S2 file in the series eFlex S series of NiTi files manufactured by 8teeth. I don't like the S1, as I said before. S1, the apical field millimeter, is very flimsy, very susceptible to fracturing. So I don't use it. I just skip to the S2 file. Again, didn't push the file, brushed with it, and again, 6% hypo. All right, so the S2 just did not want to go. So instead of forcing it and causing it to break, I went to a number 20 stainless steel K file. And what I'm doing is I'm increasing my glide path. I'm making my glide path a little smoother, a little larger. So let's go to the next video.